Hello, everyone. I'm George Beauregard, a doctor, a cancer survivor, and a father to a son who died at 32 from stage 4 colorectal cancer. I wrote about this in my recently published book, Reservations for Nine, which Matthew featured in the March 19th edition of the Healthcare blog. Today, I'm honored to have the opportunity to speak with Dr. Kimmie Ng. Dr. Ng is the director of the Young-Onset Colorectal Cancer Center at the Dana Farber Cancer Institute in Boston and the associate chief of the Division of Gastrointestinal Oncology and co-director of the Colon and Rectal Cancer Center at Dana Farber. She is the founding director of the Young-Onset Colorectal Cancer Center, which was launched in March of 2019. At the time, it was one of the only centers in the country of its kind and provides expert and compassionate clinical care to young adults diagnosed with colorectal cancer. Her research focuses on the identification of dietary, molecular, and genetic predictors of improved survival in patients with colorectal cancer, with a particular interest in the role of vitamin D and inflammatory pathways. She also conducts translational research investigating novel therapeutics, biomarkers of response, and resistance to treatment and the microbiome. She is the recipient of numerous National Institutes of Health funded grants and private foundation awards and leads several national multi-center clinical trials. She is recognized as a national expert on young onset colorectal cancer, appearing on every major television news outlet and providing insight into every major newspaper publication. I'm honored to have the opportunity to speak with you, Dr. Ng. Thank you for taking the time to speak with me. And in full disclosure, I'll let the viewers know that you cared for my son, Patrick, during his battle with cancer. So again, thank you for taking the time to talk with me.
Thank you so much for having me here. It's an honor.
So let's get right to it. First and foremost, what inspired you to develop the Young-Onset Colorectal Cancer Center?
So for a long time now, colorectal cancer has been a major problem, both in the United States as well as globally. It is the third most common cancer in the United States. And when you combine men and women, it is the second leading cause of cancer death. Now, the good news or silver lining is that if you look at all ages, the incidence and mortality of colorectal cancer has been decreasing over the last several decades, largely due to improvements in screening as well as treatments. But these benefits have not been seen in very young individuals under the age of 50. I think my colleagues and I all started seeing many years ago more and more young people with no genetic history or family history or risk factors for this disease coming in and being diagnosed with very advanced stages of colorectal cancer. And then the seminal publication from the American Cancer Society in 2017 that for the first time formally reported the rising rates of young onset colorectal cancer really cemented to us the urgent need to have a dedicated center to care for these patients, as well as to launch a multidisciplinary research effort to better understand why rates are rising in young people.
Dr. Ng, what's the age range of the patients that you have seen at the center? And how many patients have been seen since its inception?
So since we launched in March 2019, we have now seen well over 1,000 patients with colorectal cancer who are under the age of 50. I would say that our population is fairly representative of the young onset colorectal cancer population in this country as well as around the world, where the vast majority are diagnosed in their 40s. But I do also want to point out that if you look at the epidemiologic trends, the rates of rise are actually steepest in the very youngest patients. So for those in their 20s and 30s, the rates are rising the most steeply, around 3% per year for both men and women, Whereas among those in their 40s, who are, again, the most common age at which we see these patients diagnosed, it's rising about 2% per year.
Dr. Ng, what do you think is causing the shift in the age bands that you just described?
So that is a topic of intense research by my group as well as many other groups. We do know if we look at the epidemiologic trends really closely, they seem to follow what we call a birth cohort effect, where the rise in the rates tends to travel by generation. And what that means is for a person who is born in 1990, they now have quadrupled the risk of developing rectal cancer and over double the risk of developing colon cancer compared to a similarly aged person who was born in 1950. When we see this generational change in rates of a disease, it usually is attributable to a recent environmental exposure or change. And so we very much believe that it is something environmental, whether that is something in our diets or our lifestyles or the environment in general, that is likely driving this rise in young onset colorectal cancer. But what exactly those environmental or diet and lifestyle factors are is still a topic of with no good answer right now.
So, as you wrote in an editorial in a May 2021 issue of JAMA, 45 is the new 50. Given the stubborn rise in the incidence of early onset colorectal cancer, do you think 45 is young enough?
So, yes, what you're referring to is the recent change in the screening guidelines for people at average risk of colorectal cancer. The United States Preventive Services Task Force did lower that age at which to begin screening from age 50 down to 45 back in 2021. Now, I do think this is a good first step in trying to reduce the incidence and mortality of this disease in young people, particularly given what we just discussed, which is that the vast majority of people are in their 40s when they are diagnosed with young onset colorectal cancer. But also, as we just discussed, the steepest rates of rise are in those younger in their 20s and 30s, to which the screening guidelines still do not apply. So I completely agree with you. We need to have a better way to detect early or prevent cancer in these very youngest individuals as well. I think it's unlikely that the screening age will be lowered any further. And what that means it just highlights the importance of really doing the research to understand what the causes are of this rise in young people. What are the risk factors? And can we come up with a risk stratified approach that identifies the very youngest people who have a high risk profile and target them for earlier screening? I think the other avenue of research that many people are investigating and pursuing is, do we have a better screening test that's not invasive, perhaps more cost effective, that can be deployed to a larger portion of the population for screening and early detection?
Several of those points I'm going to circle back to a little bit later during this discussion. Can you tell us about what areas of research at Dana Farber that you're really excited about as it relates to early onset colorectal cancer?
We have so many different projects going on, but I will highlight a few. One of our main goals is to establish a large prospective cohort study that spans countries from around the world of patients with young onset colorectal cancer, and to collect data as they go through their treatment and surveillance, to collect serial blood samples and stool samples, as well as tumor samples to better understand the biology of their disease, and then to match all that with validated information on diet and lifestyle factors, as well as environmental exposures, so that when we do better understand the biology of why young onset colorectal cancer is rising, we can hopefully use that paired data on environmental risk factors to identify what the environmental driver might be of why that cancer happened in that young person. Part of that research study is really focused on the role of the microbiome. And there is a recent paper published in Nature that did reveal that there is a particular mutational signature or pattern of changes in DNA related to a toxin called colibactin that likely arises from an organism called PKS positive E. coli in our microbiomes. So there's increasing evidence now that the role of the microbiome may be important in why this cancer is increasing in young people. We are also looking at things like the immune system and how that might be different in younger patients compared to older patients that may have led them to be more susceptible to developing this cancer at an early age. We're looking at things like microplastics and trying to characterize the amount of microplastics in patients with colorectal cancer, comparing younger versus older patients to try to see if that may be playing a role given the rise in plastics in our environment over the same period of time. And then finally, because there isn't a lot of research on this group of people in their 40s who are diagnosed with advanced colorectal cancer, we also have a lot of studies to try to better understand what their psychosocial and supportive needs are. So as part of our center, we can better develop resources and other tools that they need to help them get through the cancer experience.
Thank you. Dana Farber also launched the Centers for Early Detection and Interception in December of 2023. And it's described as a first of its kind integrated clinic that brings together clinicians and researchers across cancer types to advance early detection of precancerous conditions and to prevent cancer from arising in individuals at increased risk. How do you interact with the Centers for Early Detection and Interception?
I am really excited about the launch of the Centers for Early Detection and Interception at Dana Farber. You know, once cancer develops and once it becomes metastatic, it is just so complex that it is very hard to treat and potentially cure. So I do think the future of decreasing the burden of cancer globally in our population is going to be through prevention and early detection. So the efforts and the research put forward by these centers is going to be extremely important. We interact with the leaders of those centers frequently. Many of our patients with high-risk conditions who are at risk for GI cancer malignancies are part of that center and are being followed very intently by that center. And we do have a number of projects that we are brainstorming to hopefully collaborate with them to help better prevent and detect early colorectal cancer, especially in young people.
So there's a projection, it's been projected that by 2030, 1/3 of all cases of colorectal cancer are going to occur in people younger than 50. And it's already known that many of those people are discovered at higher stages of disease, where the likelihood of meaningful survival or cure is lower. How do you think, I know you mentioned that you didn't think the lower screening age would likely change in the upcoming years, but what do you think as terms of the approaches with patients needs to change?
I do think that part of the reason that young patients are diagnosed with much more advanced stages of colorectal cancer compared to older patients is a delay in diagnosis. There was a survey done by the Colorectal Cancer Alliance of about 1,000 patients with young-onset colorectal cancer, where the majority of them waited for 6 months or longer after developing concerning symptoms before seeking medical attention. And when they did seek medical attention, 2/3 of those young people had to see 2 or more physicians before being correctly diagnosed with colorectal cancer. These diagnostic delays significantly increase the chance of being diagnosed with a much more advanced stage of disease, which we all know is much less treatable and curable than if you were diagnosed with stage 1 or 2 disease. So I do think this relative lack of awareness among both the general population as well as a lot of the healthcare community may be contributing to why patients are being diagnosed at more advanced stages. But we also suspect that there may be a component of more biologically aggressive disease in tumors that happen in young people compared to older people. And that's why we are so intent on trying to form this prospective cohort study and really collecting a lot of samples to understand if tumors in younger people are maybe more resistant to the current treatments that we have now. We have survival data that even though a younger person is healthier when they're diagnosed with fewer comorbidities, They can receive more treatment, more chemotherapy dose intensity. They have less adverse effects to treatment. Despite all of those advantages, they don't actually have any better survival in most studies than somebody who's in their 70s. And so this really leads us to believe that biologically, these tumors may be different than the average onset colorectal cancer. So I do think that it is important to try to shorten the diagnostic delays or eliminate them completely. And we are helping to do that by trying to raise awareness as part of our center, both among the general population as well as among the healthcare community, that rates are rising and colorectal cancer can develop in a young and otherwise healthy person without risk factors.
Thank you. I'm going to take a step back and ask a broader question about cancer screening in general. What are your thoughts about changing cancer screening from a one person, one cancer at a time approach to a multi-cancer population health approach?
So I do think there is broad interest currently in what we call multi-cancer early detection tests. And there are a variety of different technologies and assays out there right now that are currently being researched, but many of them look for changes in circulating tumor DNA that may be traveling around in somebody's bloodstream. I do think that those tests will eventually have a role in early detection and cancer screening, particularly for a lot of the cancers where established screening is not already in place. But I do want to emphasize that those tests are currently not yet ready for prime time. We don't fully understand the science behind those right now, but I do think that eventually they will play a role, but they should not replace current screening right now in terms of the official guidelines that are really backed by good data for things like breast cancer and colorectal cancer.
So from my perspective, Dr. Ng, there seems to be two camps regarding the use of these multi-cancer early detection tests. One camp that says no such tests should be FDA approved, absent compelling results from a rigorous randomized controlled trial, which would likely take many years to complete. And others who feel that given the emergence of early onset cancers and the deaths associated with that, that perhaps could be preventable. Are we now at a point where the medical community needs to think differently? And I'm mentioning this more in terms of augmenting screening and not replacing, current, gold standard screening like for colorectal cancer or colonoscopy.
Yeah.
Can we say that not screening, does harm now?
Well, I don't know if anybody knows the answers to these questions. They're very important questions. And I think the bottom line is that Dana Farber, with our Centers for Early Detection and Interception, fully believes in the importance of this concept and that it is the future to really reducing cancer burden in people globally. And so our centers are involved in multiple trials trying to characterize the effectiveness of using some of these tests for early detection. And so I think that what I would say is to encourage people to participate in these screening tests and these early detection tests in studies that are trying to investigate how they should be ultimately utilized. I do think that, despite the recommendation and the thought that they're not ready for prime time, that many people are getting these tests done. Now, the problem is that because they're not ready for prime time, we don't often know what to do with the results. And I do think many primary care doctors in the community may not know what to do with some of the results if they do come back positive. And so one of the things that we've taken on here at Dana Farber Cancer Institute is to have a multi-cancer early detection test clinic where people who do get these results that they may not know how to interpret or follow up on can be seen in our center, and we will help conduct the workup to understand if there is a cancer present and how to further confirm that. But if not, to also follow these people over time to see how things may evolve, and then to participate in the research to better understand what role these tests will have in our future.
So my next question was going to be, what's your advice to primary care physicians dealing with people under 45 regarding all this, particularly those, because they're on the front lines.
Mhm.
And as people learn more about this from pieces that appear in the, print media, television media, et cetera, they're probably going to ask their primary care physician, what do you think of all this? And for a primary care doc who's in a rural area and may not have access to something like the Center for Early Detection and Interception, what's your advice for them?
I think the most important role that primary care physicians or really any clinician who's evaluating patients who are young and who may be having symptoms is to just be aware of what the red flag symptoms are for colorectal cancer. Now, although rates are rising among young people for this disease, the absolute numbers of patients who are diagnosed young with colorectal cancer is still relatively small. And so things like blood in the stool and abdominal and pelvic pain are the most common presenting symptoms of young people who ultimately get diagnosed with colorectal cancer. But those are relatively nonspecific and can be, attributed to much more common benign diseases as well. But I would say that, primary care physicians should be vigilant about working up any symptoms that are persistent or worsening. And in particular, if there's unintentional weight loss or change in bowel habits or caliber or abdominal pain, those definitely do need to be taken seriously and worked up further. The other benefit that I can think of for primary care physicians as well as clinicians who are seeing patients in terms of early detection and prevention is actually getting a good family history. And I don't think this is talked about a lot, but if you get a good family history and find out that somebody has a first degree relative who had an advanced polyp, for example, or who had colorectal cancer, those are indications for starting screening earlier than 45. And so that can go a long way in cancer prevention and early detection. So I think those are the most important roles right now that primary care physicians can play in the early detection and prevention of this disease. I again don't think that multi-cancer early detection tests are quite ready for prime time, which is why at Dana Farber we're doing all the research studies to try to better understand how they would fit into a standard care paradigm. But these are other important ways that primary care physicians can really contribute to prevention and early detection.
Dr. Ng, what would be your advice for people under 45 who aren't quite sure what to make of all this as they see it, on the cover of Time magazine and in the Wall Street Journal and in other, media outlets?
I think that it can certainly be scary and concerning to hear about how many different cancers are rising in young people and about just what the burden of cancer is projected to be in young people if these rising rates continue. So, just the awareness of it can I think alert people to pay attention to their body and their symptoms and to promptly seek medical attention for anything concerning that may be developing. That will be important. I also think it'll be important and hopefully alert people to the importance of talking to their family about whether or not they do have a relative with a history of colorectal cancer or breast cancer, whether they do have a history of polyps and are they the concerning type of polyp that may eventually turn into cancer. I think a lot of people still don't talk to their family about some of this medical history, and it's important to encourage them to do so. And otherwise, although diet and lifestyle are probably not the sole answer to why this condition is rising in young people, it is still really important to try to live a healthy lifestyle and to consume a healthy diet. And so the things that we recommend starting as early in life as possible is to eat less red meat and have a healthier pattern diet with fruits and vegetables and healthier proteins, to not smoke or drink alcohol, to exercise and stay active, and to maintain a normal body weight.
There are lots of people who sort of look up clinical trials, when they get diagnosed, initially. And I think they're not quite sure how international cancer research centers share their work. How is that accomplished? Can you comment on that for a moment?
Yeah, I think it's a known problem that some of the ways that patients have to research what clinical trials are out there and which ones might be best for them are clunky and not easy to navigate. And I do know that there are national efforts out there to make that more easily accessible to patients. What I would say is that, patients should talk to their oncologists about what clinical trials might be available for them and that they think are the most promising and where they might be happening. Because I think many of us will know the most exciting trials that are going on and can really talk to patients about that. We all go to national and international meetings where the latest breaking science is presented, and we talk to our collaborators at those meetings, and we learn about the exciting things that are happening. So there are ways that the latest science is being disseminated and what trials are being conducted are being conveyed to the public. There is an effort among a lot of these big scientific meetings to also issue more layperson summaries that are, again, more easy to understand by the general public, and can be accessed more easily. So I think all of these efforts will help in communicating better to the general population what trials might be happening.
I'm going to pivot away from the clinical side of this discussion for a second. The high costs associated with cancer care imposes a significant burden on young adult patients with cancer. They're in the busiest years of childbearing and work lives. How does the Young-Onset Colorectal Cancer Center advise and/or support those people?
I think what you just mentioned is so critical because although we know it is difficult to receive a cancer diagnosis, no matter what age you are, we do know that young people in particular have unique challenges. And you just mentioned some of them. Financial toxicity is huge among younger patients with cancer. They are, as you mentioned, in the prime of their life. They're in the middle of their careers. They're also taking care of young families, as well as often taking care of elderly parents. And so the financial implications of receiving an advanced cancer diagnosis at this stage of life can be devastating. In addition, many patients may not have had a chance to start their families yet and are still interested in starting a family when they're diagnosed with this disease. There are high levels of psychosocial distress, a feeling of isolation from their peers when this happens. And so for all of these reasons and more, that's what really inspired us to start our Young-Onset Colorectal Cancer Center. We have a wonderful resource specialist office in place, as well as financial counselors available to speak with any one of our young patients diagnosed under the age of 50 to really help them navigate through this diagnosis, taking into consideration what their financial constraints and limitations may be. We also have hired dedicated social workers who specialize in young people with cancer to help support our patients through this diagnosis and treatment as well. And they also conduct support groups as well as come up with customized educational workshops to really help our patients understand the unique issues that they are facing as a young person with cancer. And we have found that all of these supports have really been meaningful to a lot of our patients who have been cared for at our center.
People 20 to 40 years of age, we know that they heavily utilize social media platforms to access and share information and communicate. How could major platforms be leveraged to raise awareness of this phenomenon?
We are definitely trying to have a social media presence. We have accounts on Instagram and Facebook and X, as just some examples of how we are trying to keep the general population aware of the rising rates of young onset colorectal cancer. We also use those platforms to try to raise awareness of the importance of screening and making sure everybody adheres to screening guidelines, and to make people aware of some of the symptoms that may indicate a diagnosis of colorectal cancer that need further medical attention. We also conduct a lot of our support groups and seminars and workshops virtually as well. Again, we know how busy these people are when they're diagnosed at this stage in life, and to have to attend something in person may not be possible. We also realize that there are not many centers like our Young-Onset Colorectal Cancer Center that has support groups, for example, or all of these resources. And we want every young patient, no matter where they're diagnosed or being treated, to have access to some of these tools. And so having our support groups be virtual, for example, means that any young onset colorectal cancer patient around the world can potentially access that care. So we are trying to use technology and social media and tools online, as well as traditional media like the TV and newspapers, to really get our message out internationally as well as nationally.
Thank you. I'm going to swing back to the risk factor side of the discussion here. So, along with hereditary factors, in the absence of assuming the absence of a red flag symptoms, should someone with a sedentary lifestyle, a high processed food dietary intake, obesity, moderate alcohol and tobacco use, should those be considered risk factors that would merit screening a person under 45?
It's a great question. And I do think that taking into consideration dietary and lifestyle habits and background will eventually become part of a risk stratification model for identifying young people who may be at high risk for developing colorectal cancer. Just to review, colorectal cancer is probably one of the top cancers that is most strongly linked to diet and lifestyle. And we've known for a long time that things like obesity and poor diets and sedentary behavior significantly increase the risk of colorectal cancer, whether you're over the age of 50 or under the age of 50. So we are working with a lot of epidemiologists and other scientists to try to develop robust and accurate risk models that not only combine diet and lifestyle habits, but also perhaps consider genetic contributions and influences to a person's risk of disease. And can we come up with a risk model that way and eventually conduct what we call precision prevention, right? Where we really tailor the guidelines for screening and cancer prevention according to a person's high risk profile. I do think that's the future and may be the best way to identify and detect early cancers in otherwise young and healthy people.
I do wonder, if you liken it to the Framingham risk score, right, which considered a number of variables and came up with a, percentage likelihood of having a cardiovascular event during the upcoming 10 years. I think your comment about risk stratifying individuals based on some of those lifestyle patterns and behaviors, that you mentioned, what's their diet like? Do they smoke? Are they sedentary? It'd be nice if there was a validated, algorithm that sort of put out a score that said, this person's, an 8 on a scale of 1 to 10, or, whatever how those would be valued. I think that would be a different approach in this.
Yes, and so important to really hone down and get that model correct, right?
Yes.
And I think right now, we don't know if it's just diet and lifestyle that are the reasons for why this is increasing. What role does the microbiome play? What is this PKS positive E. coli, which we think is present perhaps in the first decade of life and causing changes in DNA that can accelerate the cancer-causing process by many years? What are the environmental factors that lead to someone to have this bug in their microbiome in the first decade of life or not? So I do think there are still just so many things we have to understand about the cause of young onset colorectal cancer. And that's why the research is so important right now. We need to better identify the etiology and the risk factors, and then try to come up with that risk model so we can identify high-risk young individuals and get them screened earlier.
So the mystery continues, despite all the great efforts, that are underway researching to try to pinpoint. I don't think there's going to be a single causative agent for this. It's going to be multifactorial. And, there's a lot of work being done and a lot of work yet to be done, and certainly hopeful and optimistic about, a very good way to identify people at risk for, early onset cancer. Dr. Ng, I want to thank you for taking the time to talk with me today. This is obviously a matter of great importance for people. And again, I really appreciate you taking the time.
Thank you so much for having me.
So this concludes our conversation with Dr. Ng, who, as I mentioned, serves as the Associate Chief of the Division of GI Oncology at Dana Farber and is the founder and director of the Young-Onset Colorectal Cancer Center. I'm Dr. George Beauregard. I have a professional and very personal interest in this topic. Thank you to those who tuned in to this podcast. I hope you found this conversation informative, thought-provoking, and a call to action. Thank you.